So welcome to our webinar on the fundamentals of gentle euthanasia and supporting grieving pet parents. Your hosts will be myself, Megan Anderson.
And hello, I'm Louise Griffey.
And we're here to entertain you for the next hour or so.
Lovely to be here with you all.
And a special thank you as well to the Premier Skills Institute for hosting the course. We wouldn't be here without you. So why are you here? Hopefully it's because you see the value in improving not only your clinical approach to euthanasia, but also in better understanding grieving pet owners and how we can support them. Euthanasia is an everyday part of companion animal practice, and yet it's so little covered in our veterinary education. Even in our first years of practice, many of us are thrown in the deep end. And yet it's a day when pet owners will carry memories with them forever. It's one of the most significant and most difficult days in their life shared with their pet. But it also has potential to be the most traumatic. A bad euthanasia experience is one of the most common reasons that clients move to a different practice. And it can have a profound impact on the well-being of veterinary professionals. So our learning objectives for this course are, first of all, what is euthanasia?
And our second objective is understanding and supporting pet owners through grief and difficult decisions, which would be creating emotional safety and helpful versus unhelpful language.
Preparing pet owners for the procedure itself. Technical skills, including sedation protocols, IV catheters, and intra-organ techniques. Respectful body care, the importance of memorialisation and keepsakes.
Signposting to the appropriate support resources, and supporting ourselves and each other.
So, what is euthanasia? The etymology of the word is derived from the Greek euthanatos, which translates roughly to good death. But what is a good death? Any vet can administer pentobarbital and put an animal to sleep. But can you give them a good death? Euthanasia is not just giving a drug which results in the death of a patient. Good euthanasia means considering the needs of the pet and their family left behind.
So we must start with the basic principles of grief. And in that, the stages of grief myth. And I say it's a myth. So the 5 stages were never meant to be a checklist. They were originally observations about people facing a terminal illness coined by Dr. Elizabeth Kubler-Ross, not grieving a loved one. So grief does not move in neat steps. Owners may experience anger, guilt, bargaining, or deep sadness, but not in order. Many feel pressure to be at acceptance quickly. So telling someone they're stuck in a stage can actually increase shame. It's more helpful to normalize fluctuation than to label emotion. So instead of thinking in stages, it can help to think in waves. One day a pet owner might feel peaceful and the next they might feel intense regret. That doesn't mean that they're regressing. It means that they're grieving. So if an owner seems, for example, angry, often what's underneath is fear, guilt, or heartbreak. So the different forms of grief: anticipatory grief, so that's before the euthanasia; acute grief, which is immediately after death; complicated or prolonged grief; traumatic grief, if death was sudden or distressing; guilt-driven grief, or the main one, disenfranchised grief, which many pet owners feel, which is not socially recognised. Owners may appear practical and composed in the clinic itself, but completely unravelled at home. And grief can be delayed when people go into decision mode. Many owners hold themselves together during the appointment and just fall apart in the car. Just because someone looks calm does not mean they're coping. So again, the disenfranchised form of grief is grief that isn't fully recognised or validated by society. Many people are told quite often it was just a dog, you can get another one, at least they had a long life. So this minimisation compounds the pain. Owners may feel embarrassed by the intensity of their grief. They may apologise for crying in the clinic. They may downplay the relationship. And for many people, their pet was their safest relationship, their routine, their constant, their emotional regulator. And when that's gone, the loss is enormous, but they don't always feel permitted to show that. The veterinary clinic may be the only place where their grief is fully witnessed and validated. So grief is not a problem to solve. Let's think of it, it's a response to love. We're thinking about the first conversation here, an emotional readiness. And the subject of euthanasia is sometimes raised by the vet, sometimes the pet owner. It doesn't matter. So owners are not just making a medical decision, they are wrestling with love, responsibility, fear, and a deep, intense guilt. And for many owners, this is the hardest decision that they will ever make. Helpful and unhelpful language when the pet owners are deciding. They are usually asking, am I doing this too soon? Am I leaving it too late? Am I failing them? So unhelpful language, even if well-intended, it's time. You're doing the right thing. There's nothing more we can do. You don't want them to suffer. So why? It's because these can make things feel final. It can be directive and cold, and it's loaded with pressure. So helpful language sounds more like, tell me what you're noticing at home. What feels hardest about this decision right now? What would be a good day? And what would this look like for them at this stage? You know your pet better than anyone. So you're shifting from instructing to guiding. So when we guide instead of instruct, we give owners their dignity back in the decision. So creating emotional safety isn't complicated, but it is intentional. So it looks like sitting down, not standing over the pet owner, slowing your tone, leaving space after they speak, not rushing to fill silence, avoiding medical jargon in high emotional moments. So it also means like offering privacy without having to ask, making it clear that there is time. And of course, normalizing tears, that's super important. When an owner feels emotionally safe, their nervous system settles. When they feel rushed, their nervous system goes into panic. So anticipatory grief. Before euthanasia, many owners are already grieving. Signs of anticipatory grief: tearfulness during routine visits, hypervigilance, overanalyzing symptoms, emotional withdrawal, sudden irritability. Sometimes what looks like indecision is actually anticipatory grief. Anticipating the loss often carries guilt, am I giving up? Fear, what if I choose wrong? Overwhelm, I can't imagine life without them. So reducing fear, guilt, and overwhelm. So you're not removing these emotions, you are containing them. So helpful phrases such as, this is an incredibly loving decision to even be considering. Many owners struggle with timing. You're not alone in that. We can take a moment. There's no pressure right now. So sentences like that. So what to avoid over reassuring, over explaining medically when someone is crying, trying to eliminate guilt entirely. So guilt doesn't mean the decision is wrong. It means attachment is strong. And then guiding rather than instructing. And that sounds like, so instructing sounds like authority, certainty, finality. Guiding sounds more like partnership, reflection, shared responsibility. Instead of saying it's time, try, based on what you've shared, I'm concerned that their quality of life is declining. How does that sit with you? And ask them that question instead of, we should schedule euthanasia. Try, would it help to talk through what the process looks like so you can feel clearer about the next steps? So pet owners don't need us to take control of the decision. They need us to stand beside them while they make it. So how an owner feels in the decision-making phase will shape how they grieve afterwards.
So then when we move to the clinical side of things, we do need to prepare the pet owner for this process. Some pet owners are surprisingly rational and clued in about their pet's overall well-being. Others find it very, very difficult to separate their own emotional involvement from the reality of their pet situation. For these clients, a calm, open but guided discussion can help them better understand their pet's current and expected quality of life. This could be as simple as choosing a handful of activities or behaviours that they know indicates their pet is happy. Going for a walk, playing with their toys or another dog in the home, jumping up at the window to watch activity outside. How many of these are still happening? Sometimes I'll ask questions like, how many of the last 10 days were good days? Sometimes using structured tools like quality of life scales can help also provide a degree of objectivity. If you're concerned a pet owner may not be truly understanding how limited their pet's time is likely to be, try the surprise question. That is, at what point would you be surprised if your pet were still with us? 3 days? 3 weeks? 3 months? Now, if their pet is very different than yours, it creates an opportunity for open discussion rather than a client feeling they've been given an ultimatum that their pet has to be put to sleep at a particular point. Once the client's begun to accept that euthanasia is likely to happen soon, we should encourage them to consider how they would like the appointment and aftercare to be handled when they're not in a heightened emotional state and might make decisions they regret. So this could include whether they want euthanasia to happen at home or in the clinic, who is able to be or wants to be present, what will actually happen during the appointment, what are their aftercare choices. And then give them an opportunity to voice any specific fears, questions, worries, or requests. They might say no, they've nothing to add, and that's absolutely fine. But just asking the question helps them to feel that their needs are being considered.
So the euthanasia appointment, pet owner's emotional experience. So the euthanasia appointment itself may last anywhere from 20 minutes to 2 hours. Of course, that varies, but emotionally it will live in that owner's memory forever. So what owners remember most is not the drug name, the catheter placement, the exact timing. They remember the tone in your voice, whether they felt rushed, whether someone made eye contact, whether their grief felt safe or awkward. So what owners remember forever, owners often replay the last thing that they said, the last thing that you said, the moment their pet's body changed, whether the room felt calm or clinical. So years later, owners rarely remember the protocol. They remember how the room itself felt. So they remember if you slowed down, if you warned them gently before physical changes, if you gave them permission to stay, if you gave them permission to leave. So tone, silence and pacing matters more than wording. So a calm, steady tone communicates safety, stability and competence. A rushed tone communicates discomfort, urgency, and emotional avoidance. So silence is powerful. Many professionals rush to fill the silence because they feel uncomfortable. They want to reduce distress, but silence can say, I'm here, this moment matters, you don't have to hurry. If we rush, owners' nervous systems rush. If we slow down, they begin to settle. So pacing also matters. Pause before administering medication. Tell them what's happening before it happens, and give space after death is confirmed. Language during the euthanasia itself. This is where small phrases matter enormously. So helpful language such as, I'm going to give the sedation now so they'll feel very sleepy. Or you can keep talking to them while they can still hear you. Or take your time. Or I'm here, I'm right here. There's no rush. You're doing something incredibly loving. When confirming death, their heart has stopped. Say things like they've passed peacefully. They're at rest now. Gentle, clear, no medical jargon in high emotional moments. Unhelpful language to avoid. So even well-meaning phrases can wound. So avoid the at least phrase. At least they're not suffering. At least you had 14 years. You have other pets. You can always get another. He lived a good old age. It was only a dog or cat. This happens every day. You did the right thing. Said too quickly without context. So try not to cry something that's not to be said to the owner. Why? Because these minimize the attachment, they bypass grief, they suggest replaceability, and they really do just shut down emotion. So the word at least often feels like a closing of the door on someone's pain. When emotion peaks, so pet owners may collapse into sobbing, become very quiet, apologize repeatedly. They may say, I'm sorry to their pet. So helpful responses would be, you don't need to apologize. It's okay to cry. This is so hard. They were clearly very loved. So avoid trying to distract, changing the subject, kind of immediately moving to paperwork just to avoid those things.
So the client is arriving to the clinic, or you are arriving to their home for the euthanasia appointment itself. For in-clinic euthanasias, remember the client is feeling emotional, likely vulnerable and self-conscious. So where possible, they should be escorted immediately into a consultation room for privacy, even if the attending clinician is not ready to start the appointment just yet. If this isn't possible, offer them the option to wait in their car rather than a reception area. Creating the right environment in the clinic, this is largely up to us. Carefully worded signs in reception can remind other clients to keep their voices quiet or to step outside with noisy children. Place soft blankets on the exam table or floor. Ensure enough chairs are present for all family members that want to be there. Providing tissues and leaflets with information on grief and bereavement support. Give them a step-by-step run through. How is this appointment going to proceed? Are you going to start with a consent form, with payment, giving sedation, when they can have time, when they can step out? All of these things can really help an owner prepare psychologically for what is coming. I generally start appointments with the consent form and confirmation of aftercare choices rather than trying to discuss aftercare when the pet has passed away. And then payment. In my own experience, most clients prefer to make payment at the start of an appointment rather than after their pet has been put to sleep. Most clients now have wireless card readers, which means this can be done in the consult room rather than reception. In some cases, clients might be permitted to pay for the appointment at a later date, but you'll have to defer to your own clinic's policy on that one. So your paperwork is done, you've signed the consent forms, payment is sorted, you're going to give sedation. I firmly believe that sedation, with the exception of emergent situations like status epilepticus, all pets should be given sedation prior to euthanasia. Why? It minimises pain and stress for the patient. It avoids separation of the pet for their family. This is incredibly important. You wouldn't believe how many times when I attend home euthanasias that bad experiences or traumatic experiences can be very strongly tied to a family's pet being taken away from them when they only have hours or minutes left to spend with them. Every minute counts. It is overall a calmer and more peaceful experience for both pet and owner. When giving sedation, I usually choose the subcutaneous route as it's best tolerated by most animals. Remember, we want to avoid pain. Time to onset for subcutaneous sedation is usually about 10 minutes, which is generally very doable. Once sedation is given in a clinic setting, sometimes I'll step out of the room to prepare other items I'm going to need, but I'm monitoring the consult room via CCTV so that I can step in if needed. If a patient is particularly fragile, such as if they have advanced cardiac disease, everything should be prepared in advance and the attending vet should absolutely stay with the patient as sedation takes effect. Once it's kicked in, I'll give the owners the option to step out if they wish, but often the pet looks very peaceful and calm once sedated, and most owners choose to stay, even those that initially said that they would step out. In terms of specific sedation protocols, there's no perfect option that suits every patient or every clinician for that matter. We also have to consider the availability and costs of drugs. So the first most commonly used option would be alpha-2 agonists. These provide excellent sedation and muscle relaxation. Xylazine is readily available and affordable, though I tend to avoid it because of the high rate of vomiting. My personal default is either medetomidine or dexmedetomidine. These are usually readily available in practice and better tolerated. Zen-alpha is a newer option, which contains vatanoxin as well as medetomidine. The vatanoxin is intended to help mitigate cardiovascular side effects, but it is more expensive, less commonly stocked, and personally, in this scenario, I don't find the vatanoxin to be of any particular benefit. Next up are the opioids. So we've got butorphanol, which is a good addition to most protocols as it provides better sedation than some other opioids. And it also does give some analgesia within about 15 minutes or so, which is usually a nice addition. Buprenorphine, methadone, pethidine can also be used. Although the sedative effect tends to be less potent, they are also more likely to sting on administration. So again, remember, we want to avoid causing pain. Then we have the benzodiazepines. These are great, especially for cats where we're trying to avoid our alpha-2s. Also very helpful, again, for those fragile patients, for example, cardiac patients where we're concerned about cardiovascular effects. They can also be quite good anxiolytics, especially in older, frail or debilitated pets. However, again, remember these are generally acidic and can be painful on injection. So dilution is advisable and careful, slow injection to reduce this. Midazolam tends to be my go-to. Diazepam is also readily available. Zolazepam is available as Zoletal, which is a combined formulation with tetraethylamine. This is a very nice option, especially for cats, where we're often going to want to add a dissociative, but quite an expensive option in Ireland at the moment, so not one that I'm commonly using. And then is promazine, generally very well tolerated, readily available, nice to combine with an alpha-2 in dogs because it reduces some of the cardiovascular side effects, which is a particular benefit when we're looking for venous access. And an added bonus is the availability of the oral mucosal gels, which is a great option for patients which are particularly reactive either to handling or injections. Look, every vet has their own preferences. There's no one-size-fits-all protocol. You'll have to make adjustments based on the overall condition of each patient. My default combination for dogs is medetomidine, butorphanol, and acepromazine, and for cats is butorphanol, midazolam, and acepromazine. So once sedation has kicked in dogs, my preference is generally IV administration of pentobarbital where possible. I generally feel most comfortable placing a catheter. Butterfly needles are also perfectly acceptable if you're confident with their use. Catheter placement should generally be done in the room with the owner present if at all possible. Again, remember, every moment counts here. These are the last minutes that a client is going to have with their pet. We don't want to separate them if we don't have to. Exceptions might be if you're very inexperienced in IV catheter placement and are likely to need assistance from colleagues, or if the owner is uncomfortable with the sight of needles or blood, in which case you'll just have to use your best judgment as to whether it's better to temporarily move the pet to another room or suggest that the owner briefly step out. I would also suggest that you purchase a good tourniquet and get comfortable with its use. It can really, really help the flow of the appointment if you don't have to wait for a colleague to be available to assist you. So choosing a vein, ideally we want to be mindful of any areas of pain. If your patient has severe osteoarthritis in their elbow, a hind limb might be preferable. We also want to take into consideration the owner's desired proximity to their pet. Do they want to be close in kissing their dog's forehead, in which case maybe a cephalic vein is not the most ideal option. But generally speaking, especially if you're still gaining confidence, it's best to start with veins you're confident using. The cephalic vein is the one we're usually most familiar with. It's perfectly suitable in most situations. But at the end of the day, any vein you can get into is a good vein to use. And don't forget, we all have bad vein days. There are all sorts of reasons why gaining venous access can be difficult. It could be distal limb edema, the presence of tumours, pain, hypersensitivity or allodynia, poor vein quality, blown or collapsed veins. If this happens, it's okay. Consider other points of venous access. Dorsal pedal veins in the forelimb, lateral saphenous veins or dorsal pedal veins in the hind limb. They're all perfectly suitable. When we're giving IV pentobarbital, we need to be mindful of how we give it, how much we're giving. If your catheter placement leaves you in a position which physically obstructs the owner's access to their pet, attach an extension set. Consider your dose of pentobarbital. The standard dose when given intravenously is about 85 milligrams per kilogram. But there are different concentrations of pentobarbital, so you need to be mindful of if you're using a 200, 300 or 400 mg per ml solution. Consider the viscosity of the solution that you're choosing versus the catheter gauge that you've placed. Some clinicians give propofol before giving pentobarbital at a rate of 4 to 6 milligrams per kilogram. This can reduce the amount of pentobarbital needed by as much as half, although I don't generally find it necessary unless there's a supply issue with pentobarbital. When you give your pentobarb, the rate of IV administration should be slow, and I mean very slow. For the 200 mg per ml solution, my target rate is 0.1 ml per second or less. This allows the body to shut down gradually, which means we're minimizing the incidence of post-mortem changes which can be upsetting to pet owners. Things like agonal breathing, muscle tremors, passage of urine or feces. What if you can't get a vein? Happens to the best of us, and it's okay. That's why we have intra-organ techniques. But, and this is a very important but, intra-organ injection is painful, which means we must use a dissociative. The lethal as I said before, great option for cats. If cost is not prohibitive for you, ketamine does the job just as well. In cats, intrarenal administration is generally actually my preference over intravenous. So I give ketamine as my default protocol once my sedatives have kicked in. Make sure once you've given your dissociative and allowed a little bit of time for it to take effect, that you're checking your reflexes. I tend to default to checking withdrawal reflexes. Anecdotally and from personal experience, the palpebral reflex tends to be a little bit less reliable, as some patients will continue to have a mild reflex present even when withdrawals and pain sensation are absent. So give that toe a good pinch, and if you know reaction, you're okay to proceed. Intrarenal techniques, as I said, my go-to for cats. Really nice mobile kidneys in cats. Generally, quite well tolerated in terms of owner perception, quite accessible. Just remember that your dose rate needs to be increased. So instead of your usual 85 mg per kg dose, you need to use more like 255 mg per kg. Intrahepatic, possibly one that people are a little bit less familiar with, but one that I've found incredibly useful in dogs when you can't find a vein. You're essentially aiming for just underneath the caudal end of the sternum. Sometimes if you draw back on your syringe, you'll actually get a little flash of blood. You don't always, and that's fine. Generally in this region, if you fan with a long needle, so I would usually use 1.5 or 2 inch needle into a couple of locations, you will find the liver. It does take a little bit longer to take effect compared to an intravenous administration, more along the lines of 5 to 10 minutes. And again, you do need to use an increased dosage, not as high as the renal dosage, but something close to 170 mg per kg. Intracardiac. This is one that is very effective and can be very useful if you're skilled at locating the heart, generally just caudal to the point of the elbow. Your dosage here is the same as the intravenous dosage. However, I would just be mindful of how this is going to be perceived by pet owners. I would definitely advise use of a blanket, if at all possible, to shield the view of the injection from pet owners. The heart, although we as rational, logically thinking clinicians mightn't carry any reservations about use of the heart, especially when we know the pet is under anaesthetic, there is something very emotional about inserting a needle into a pet's heart that can be upsetting for pet owners. So I would use this technique with caution in certain circumstances. It wouldn't be my top choice unless I really feel that it is the best choice for that patient. Lastly, we have intraperitoneal. This would be probably the least common route that I would choose. There's absolutely nothing wrong with it. It is acceptable to give an intraperitoneal injection without a dissociative anaesthetic on board because you're not technically injecting into an organ. However, you will need to use a high dose rate, again, your 255 mg per kg, and it will take a while. This could take anywhere from 15 to 45 minutes to take effect. So it is an option, but really probably best used when it's your only good option. When you have given your sedation, you have your plan in place for how you're going to proceed. This is when things often start to feel very real for many pet owners. So before you move to actually start preparing to give your pentobarbital, give owners the option to have some time privately with their pet. Not everyone will take the offer, but for many, being given this last opportunity to privately say goodbye is deeply appreciated. So before you then administer your pentobarbital, it is important to clearly inform owners that this is the final step and ensure they are ready for you to proceed. Communicate clearly how you are going to give the injection and how it will affect their pet's body. Reiterate the possible post-mortem reflexes that may occur. I have my own little script for this. Develop one that feels right for you. Just remember to use simple rather than technical language. And remind your clients that it is okay for them to step out at any time. When you administer the euthanasia solution, if possible, create some physical distance to allow the owner to be close to their pet. Use blankets as a visual screen for intra-organ administration. And as Louise said, remember, silence is okay. Some clients are very chatty, some are completely silent. Just follow their lead. And then it is very important to verbally confirm that death has occurred. Once you have confirmed that their pet has passed away, many owners greatly appreciate, again, being allowed to spend some time privately with their pet's remains, especially if they have chosen cremation and this is their last opportunity to do so.
Definitely, I'd agree with Megan there. Having time alone matters. And why does it matter? Because it allows the reality of the loss to gently begin to sink in. So owners can say things they may not have been able to say out loud before. It gives them space for physically being close to their pet, holding them, touching them, talking to them, and it helps prevent the experience from feeling rushed or clinical. So it does create a more peaceful and less traumatic memory of the goodbye itself. And that moment, if it's rushed, it can leave people feeling like something was unfinished. So time doesn't take the pain away, but it allows the goodbye to feel complete. So after death, so the immediate emotional support. So after death is confirmed, this is a delicate moment. So don't rush to remove the body, to start forms, to transition to logistics. So instead, say it's something like, I'm going to step out and give you some time, take as long as you need. If you'd like more time, just let me know. So the moment after death is often when shock sets in, even if the euthanasia was planned and peaceful. Even when owners were prepared, the finality can feel sudden. The room can feel different and time can just feel totally distorted for the pet owner. So initial grief responses. Normal immediate responses would include numbness, disbelief, repeatedly asking questions, apologizing to the pet, saying, I can't believe they're gone, sudden intense sobbing, or becoming very quiet and withdrawn. Shock is not denial. So it's the nervous system protecting someone from too much emotion at once. So pet owners might say, they might forget what you've just explained. They need information repeated. They seem strangely calm. So calm does not mean unaffected. Sometimes the most composed pet owner in the room is the one who will struggle the most once they walk out the door of the clinic. Normalizing shock and regret. So almost every owner experiences some version of, was it too soon? Did I wait too long? What if we tried one more thing? So try to avoid saying, no, absolutely not, and not to interrupt them. So, don't say, don't think like that. You can't torture yourself. There was nothing else to do. Unless medically very clear, and even then the tone matters. So these can feel like emotional shutdown. So instead you might try, it's very common to question yourself afterwards, or that shows how much you care, or from a medical perspective, this was a compassionate decision. Or things like I've said before, you made this decision out of love. So you can notice the difference. You acknowledge the emotion first and then gently provide reassurance. So To try and avoid over-reassuring too quickly, shutting down regret with certainty, immediately reframing into positivity. This is not the moment to solve guilt, it's the moment to acknowledge it. So what not to say versus what to say. So to try and avoid saying things like, at least they're not suffering, it was the right decision, they had a good life, kind of what I said earlier. You did the kindest thing, you'll feel better knowing you did the right thing. So why? Because obviously the nervous system is in shock. Even factual statements can still feel dismissive if they override the emotion in the room itself. So instead you might try saying things like, I can see how much this hurts. This is such a hard goodbye. You love them very much. There's no easy way to do this. It's okay if this feels overwhelming. Notice that these statements don't fix, they validate. So rushing into practical mode. So avoid, right, I'll just get the paperwork. So what would you like to do with the body? We'll take him through now. If you could just sign here. So even if logistics are necessary, the tone and the timing matter. So instead try to say there's absolutely no rush. When you're ready, I can talk you through the next steps. Take a few moments. I'll step outside. I'll guide you through everything gently. So avoid comparing or generalizing. We see this every day. I know exactly how you feel. Most people feel this way. Time heals. So these kind of statements dilute the pet owner's grief. Instead, try things like, everyone experiences this differently. How you're feeling right now is completely okay and there's no right way to react. Those kinds of statements. This kind of restores the pet owner's autonomy and even their dignity. And simple phrases, they knew you were here. You gave them comfort at the end. You did this out of love. I'm really sorry you're going through this. We can't remove the grief, but we can prevent adding to it. So in that room, you were not just performing a procedure, you were witnessing a goodbye. The way this appointment is handled will really shape not only how owners remember their pet's death, but how they remember themselves in that moment. There's also a practical reality here. The experience an owner has during euthanasia appointment will often determine whether they return to your clinic with their remaining pet, if they have one, or if and when they ever welcome another pet into their life. So if they felt rushed, dismissed, minimized, they may not come back. Not because of the medical care, but because of how they felt in the room itself. But if they felt respected, emotionally safe, and that trust will stay with them even in their grief. So end-of-life care is often the final chapter of a client relationship. It is also sometimes the beginning of a long-term one. Compassionate communication often builds loyalty. Minimizing language erodes the trust. So how we handle goodbye shapes whether there is ever another hello.
So you've performed your euthanasia and we now have to handle the pet's remains. And the importance here of respectful body care can't be underestimated. We should handle pets' remains as if the client is watching us do so, with kindness and respect. If a pet owner is taking their pet's remains home for burial, give safe burial advice regarding depth, an absolute minimum of 3 feet, proximity to water sources, relevant legalities, etc. If you're using a cremation service, if at all possible, I strongly advise you to visit your crematorium of choice. I appreciate for assistant veterinarians that, this may not be a decision that's up to you. But certainly if you are, a director of a clinic or running a home euthanasia service, this is something I would strongly encourage, and we should be looking to see, do they handle pets' remains respectfully? Is there a traceability system in place? Would you be happy to turn your own pet's remains over to this crematorium? I'd also like to just take a moment here to specifically highlight a product I love, which is the Euthabag. I don't think anyone, especially anyone who cares enough to take part in this webinar, feels good about putting a pet's remains in what is essentially a heavy-duty bin bag. And we are just fooling ourselves if we think that pet owners don't know that this happens. And for those who take their pet home for burial, I think personally that, at least in Ireland, we are lacking in the support and guidance we give these owners, let alone lacking in our consideration for any environmental concerns about burying a pet's remains, which are now full of pentobarbital. Euthabags feel, kind of from a tactile point of view, they're not too dissimilar to a reinforced canvas. It's a waterproof material, it allows for easy transport of remains, and it closes with a zipper. Be surprised how important that can be to some pet owners. It can be buried with the pet's remains inside. It allows natural decomposition via microorganisms, but prevents leaching of pentobarbital into the surrounding soil. I always offer it to clients who have chosen burial, and they rarely turn it down. Most are actually incredibly appreciative. I would strongly encourage every practice to ditch the plastic bags and make this your default. You, your team, your clients will all feel so much better about how body care is handled. And if cost is an issue, roll it in. Adding 10, 20 quid to the cost of euthanasia will cover it.
So immediate in-clinic keepsakes. So these are often prepared by the veterinary staff right at the time of the appointment. So these would be, for example, ink paw prints, a simple ink impression of the pet owner's pet, their paw on high quality cardboard, including their name and the date. Another example would be a lock of fur, a small cutting of fur often tied with silk ribbon placed in a small glass vial or decorative organza bag. Another option, clay impressions, a more tactile option where a paw or nose print is pressed into air dry clay or specialised foam to create a 3D mould. So cremation-based memorials. So if they choose individual cremation where the pet is cremated alone and their ashes are returned to them, they can usually choose from scatter tubes, biodegradable cardboard tubes designed for easy scattering in a favourite park or garden, often kind of decorated with nature scenes. There's caskets and urns. Options range from traditional wooden caskets with brass nameplates to sleeping cats or breed-specific dog figurines made of resin or brass. Tribute frames. These look like the standard photo frames but have hidden compartment in the back or side to hold a portion of the ashes discreetly. There is also jewellery and specialty items. Many modern clinics offer catalogues, for example, for memory jewellery that can be ordered through their cremation partners. So, for example, ashes in glass or resin jewellery, a small amount of ash is placed, fused into the glass bead or contained within a silver locket or a ring or a keychain. There's also memory bears, a plush teddy bear that has a small zippered compartment to hold a token amount of ashes or a favourite colour. So living memorials is another option. So a tree or a flower planting. Some services offer seed cards, so which are paper embedded with wildflower seeds that you can plant in your garden. And then many people choose to make charitable donations. Many owners, they often choose to make a donation in memory of to their local charities such as ISPCA Ireland or wherever the charity of their choice that they're passionate about is.
So, in some cases, we know as clinicians that a euthanasia did not go to plan. We struggled with venous access, we forgot to warn about abdominal breathing, or in rare cases, the patient was so frail that they actually passed away just with sedation, and we didn't warn the owners that this was a possibility. Sometimes nothing has gone wrong as such, but we can see that the owner is visibly upset or distressed by what they have witnessed.
Yes, and also from, say, the pet owner's perspective, if something doesn't go as expected during euthanasia, it can be very distressing and sometimes even traumatic if it's not acknowledged. So what matters most in that moment is not perfection, it's how it's handled. So what the owner may be feeling would be like shock, confusion, fear that their pet suffered, guilt, did I make the right choice, distress about how the memory will stay with them even. So what helps from a veterinary's perspective, acknowledge it gently and honestly, even saying something like that didn't go as smoothly as we would have liked and I'm really sorry, or offer simple, clear reassurance without overwhelming detail, although it may have looked upsetting, they were not in pain. So something like that. So stay calm and present, your tone will regulate the room. Allow space for emotion and questions and don't rush past it. And what to avoid would be ignoring or brushing past it, overly technical explanations like Megan has mentioned, and becoming visibly flustered or rushed. So when something doesn't go to plan, it's the honesty, reassurance and presence afterwards that shapes how that experience is carried.
In my own experience, communication is everything. Offering calm, clear explanation along the way if things aren't going quite to plan can really help clients understand and feel reassured that everything is under control. So for example, if I can't get a vein after 2 attempts, I will say something along the lines of, "That's okay. Ill and older pets often have very weak veins, but not to worry, we'll move on to plan B. Instead of continuing to poke at him to find a vein, I'm going to give another medication to put him fully under anaesthesia and then give the final injection into his belly instead. It can take a little bit longer, but it's just as peaceful for him." If a client is still visibly unnerved immediately after euthanasia, simple acknowledgement of this and some reassurance is all most people need. But if you still feel that any discontent is present when you leave the appointment, I really recommend a phone call follow-up in 24 hours.
So client aftercare and following up. The euthanasia appointment may be over, but the client's grief journey is just beginning. So follow-up care communicates that support didn't end when they walked out of the room, for example. So collection of ashes. So offer collection in a private room if possible, not at reception. Use the pet's name. So move slowly and allow space. Instead of "you're here for the ashes" question, try "we have Charlie ready for you. We can go somewhere quiet." So this moment often reactivates grief and privacy does matter. So a sympathy card, handwritten if possible, include the pet's name, signed by the whole team. Even one personal sentence makes a huge difference. Administrative care is crucial, so mark the pet as deceased on the system. Remember to stop vaccination reminders or automated texts. Inform all of the team members. A reminder message arriving weeks later can feel very distressing for that pet owner. Also offer a courtesy follow-up call, a short check-in, even 48 to 72 hours later. Just saying something like, "we just wanted to see how you're doing." So no fixing, no rushing, just acknowledging really. So signposting to support. So normalize external support in a gentle way if possible. So you might say something like, "if at any point you feel you need extra support, there are services available." You can mention, of course, my own business, Light After Loss. They can book a one-to-one pet loss support session. They can access free grief resources. They can listen to a dedicated pet loss podcast. And if you are listening now and you would like pet loss support leaflets for your clinic, you can contact me directly through my website. There are also places like the Blue Cross, and they offer email and live web chat support, but the phone line is just UK based and Northern Ireland. It's not in Southern Ireland as of yet. So frame it as an option. You know, some people find it helpful to speak to someone outside of their family or friends. It's simply there if you ever want it. Like that's the kind of option that they would need. So optional gentle additions the clinics might consider: maybe a remembrance candle during the appointment, a memory board or tribute page, or an annual remembrance acknowledgement if done sensitively. So aftercare isn't about grand gestures, it's just about making sure grief isn't met with silence.
So last but not least, I think it's very important here to acknowledge the impact that euthanasia can have on the well-being of the veterinary team. If you have done even a handful of euthanasias, you've surely heard comments from clients along the lines of, I don't know how you do this, or this must be the worst part of your job. I wanted to be a vet, but I could never do it because I just couldn't ever put an animal to sleep. For me personally, while euthanasia carries a lot of emotion and often a lot of sadness, I wouldn't consider it the worst part of my job. I truly believe in the vast majority of cases it is a kindness to save our pets from inevitable pain and suffering. But that doesn't mean its impact should be minimised, and it doesn't mean that that's the case for every veterinary professional or for every euthanasia appointment. Everyone's capacity to handle the emotional strains of euthanasia is different.
Definitely. And I know that we've spoken a lot, myself and Megan, a lot about the emotional experience of the owner, but we can't ignore the emotional experience of the veterinary team and repeated exposure to grief. You know, if you are repeatedly present at one of the most significant moments in someone's life, and, you know, that has an impact. Even when euthanasia is compassionate and peaceful, it's still a loss, it's still emotional labour, and it's still holding space for intense distress. So holding grief all day and then moving straight into the next consult requires enormous emotional regulation. So compassion fatigue and emotional suppression is what happens sometimes. Many of you have learned to stay steady in the room, but sometimes that steadiness comes at a cost, suppressing your own reaction, not having time to decompress, and carrying unresolved moments home with you. So being professional doesn't mean being unaffected. Moral stress around euthanasia that you might acknowledge. So disagreements with families, financial limitations, decisions that feel too soon or too late, performing euthanasia when you personally feel conflicted. So sometimes you are not just managing grief, you're managing ethical tension. So permission to feel, like you are allowed to feel something. It doesn't make you weak, it makes you human. And perhaps if you don't create space to process what you absorb, it will accumulate. So gentle encouragement would be in the form of the importance of debriefing as a team, checking in after a difficult case with each other. So small rituals, even 60 seconds of a pause, and peer support within the clinic itself.
And remember, just as you signpost support for clients, you must also give yourselves and your team permission to reach for professional help when the emotional load becomes too heavy. In Ireland, the Irish Veterinary Benevolent Fund works in conjunction with VetLife to provide a 24/7, 365 urgent support line. You can email the Irish Veterinary Benevolent Fund, or there is a link on their website where you can contact them anonymously. Vet Support also provides confidential support to vets in Ireland. You can email their general support email, which is info@vetsupport.me. They also have little bios of each of their volunteers online. If you find someone that feels like a good fit for you, you can contact them directly. So last but not least, a very big thank you. Thank you for, I suppose, valuing the importance of this topic. And thank you for attending this little webinar. Greatly appreciated.
Thank you so much, everybody.